Good day, everyone. I am Ronald, the moderator for this webinar. I welcome everyone to today's webinar that will be on Informed Consent Update, Maneuvering the Maze CMS Joint Commission's DNV and Other Standards. I want to introduce our presenter for today, that is Laura A. Dixon. Laura A. Dixon, BS, JD, RN, CPHRM, was COPIC's Director of Facility, Patient Safety and Risk Management and Operations from 2014 to 2020. Ms. Dixon has over 20 years of clinical experience in acute care facilities, including critical care, coronary care, perioperative services, and pain management. Laura holds a Bachelor of Science degree from Regis University, RECEP of Denver, a Doctor of Jurisprudence degree from Drake University College of Law, Des Moines, Iowa, and a registered nurse diploma from St. Luke's School Professional Nursing, Cedar Rapids, Iowa. She is licensed to practice law in Colorado and California. I would now like to hand over the floor to the speaker. Over to you,
Okay,
Laura.
great. Thanks very much, Ronald, and welcome everyone. As our moderator mentioned, we're going to be talking about informed consent. Now you think, well, we've had this around for years and years and years. What's new? What's different? Well, you'd be surprised. They have added, especially for acute hospitals, a very important portion to informed consent. We're going to cover that, of course, while we go through there. But we wanted to present this program because anybody, any facility that participates in Medicare and Medicaid, you have to follow these regulations. And it's for all patients, not just those who are on Medicare. So let's go ahead and get started. I just want to do a brief overview of the purpose also behind today's program. So how does all of this work? Well, the regulation itself starts in the Federal Register. Now, there have been some changes, especially for acute hospitals. So this was what the appendix looks like for the overall manual. For the particular manual, for Appendix A, your last update was in April of this year. And for the memos, again, these go to their surveyors. You have access to them. So deficiencies, I like to talk deficiencies briefly. It includes all types of hospitals, acute, critical, small hospitals. For informed consent deficiencies, here's just a few listings of them. One, so I want to talk about some of the cases. One in particular, the physician's responsibility. We cannot delegate that discussion. So the major component of what I want to talk about today are the conditions of participation. I'm going to focus on acute. These are, again, if you participate in Medicare or Medicaid payments, you must do this for all patients. And so, again, criticals, acutes, doesn't matter. Just check your state law. So as far as Appendix A, there are 3 sections that talk about informed consent. And there is a website that does talk about it for CMS and FAQs on informed consent. So let's start off with the first section in Appendix A. That is under the patient rights section. So it's tag 131. And again, they have a right to refuse treatment. They can ask someone to be their representative, but overall you have to have policy and procedures on informed consent and decision making. Advanced directives is also included under informed consent. 90 million Americans, low health literacy. 65 million Americans, that's English is not their primary language. Let's go on to the medical records section now within the acute manual. You have to have a properly executed form for procedures and treatments that usually it's for all surgeries, unless it's an emergency. You want, of course, the name of your hospital. Where is this going to take place? There is also must be a statement, optional elements. The surveyor will verify that you have, your medical staff has a list of those procedures and treatment that do require consent. Now the surgery section. It's in 955. It's a properly completed form for the operation must be in the chart before surgery, unless it's an emergency. They have guidelines, benefits. There's just some guidelines to include. What are their benefits with having this surgery? Anesthesia, doing a separate anesthesia consent form. So policies, who can obtain the consent? That has to be spelled out in your policy. Here's just some of the optional elements that surgery section spelled out, a description. So here's just some of those important surgical tasks. These are the ones CMS has listed. Residents, please include that when they do participate. So this is a recent memo that just came out in April. Again, it was part of that April update to the acute manual. And it talked about when we have an absence of informed consent. The surveyor, so back to what the surveyor is going to do, they will make sure that the medical staff has spelled out what surgeries or procedures have to have an informed consent. All right, we're moving along quite well. So I'm going to go now to critical access hospitals and the informed consent sections on it again. So let's start with the clinical records. It is very brief. In section 1110, there is evidence of a properly executed form. So like with the acutes, it has to have the name of the patient, include in there the date and time. Under surgical services for your critical access. Likewise, all inpatient and outpatient procedures. Again, the required elements, name of the patient, name of the hospital, name of the procedure. They still left out, they call it significant surgical task rather than important part, signature of the patient, date and time you got consent. Minimum explanation of why are we doing this procedure? What is the nature? I'm going to go to Joint Commission now. There is a standard in two sections. One is a patient rights section, and the other is the record of care. So in the record of care, likewise, the record has that information that reflects care, treatment, and services. EP, that's the elements of performance. A properly executed consent form must be in the chart before surgery unless it's an emergency. You honor the patient rights to give or withhold consent. It talks about the process that takes into account what are the patient's needs and their preferences. RI, patient rights section, says we have to have a written policy on informed consent. The discussion has that process about what that proposed care treatment is. Make sure that the patient, you have to ensure the consent for those who have blood transfusions. Yeah. Joint Commission has what's called quick safety. So now I'm going to switch over to what's called DNV. What is DNV? It's called Det Norske Veritas. This is a Norwegian company. Must have a properly executed consent form unless it's in an emergency. It must include all of the mandatory elements that CMS has spelled out. Surgical consent form, the policy has to describe. They talk about in here the optional contents in the medical record. The documentation has to include that consent. Now, I do want to talk about some standards from your professional organizations. American College of Surgeons, American Society of Anesthesiologists, ASA, AORN. They have these listings for health care. They even include American College of Surgeons for surgical risk, that risk calculator. So I've just got a screenshot here of what it looks like. I have training modules for you, by the way, from AHRQ and Joint Commission to improve getting informed consent. And AHRQ, it's great. This one is free. Again, you can download it, how you do that. It helps not only your physicians, but also nurses, even your executives. It helps understand. So again, Ronald, thank you very much for your help. And so with that, Ronald, I'll have you take us and close us out. Just want to thank everyone who did participate and who listened. And thank you very much, Ronald, for your assistance.
Thank you, Laura. Thank you so much. And that concludes the session for today. Thank you, everyone, for participating. You may all disconnect now. Have a great day ahead. Thank you.